My name is Malia Nogel. I'm an epidemiologist with Spokane Regional Health District. And in May 15th, actually, of this year, I took over the gap analysis project that evaluated some of the Region 9 frontline facilities on readiness and identify, isolate, and inform. So a little background, and some of this is duplicative of what Krista just presented, so I apologize for that. But in 2014, we had an Ebola outbreak that affected several West African countries. In September of that year, we had our first patient present at a Dallas hospital where there were some issues identified. Not only had the patient been sent home with a diagnosis of something that was not Ebola, but he had returned, and in course, once it was discovered he had Ebola, he had actually infected 2 of the hospital staff. So from there, in 2015, NETEC was formed, and this was to help prepare the U.S. hospital system for Ebola and whatever else might come beyond Ebola. And then, of course, in 2015, a Sacred Heart received the funding and developed the Regional Ebola Treatment Center for Region 10. So identify, isolate, and inform. I apologize that it's blurry up here, but there should be a couple of the papers going around right now. The CDC developed this guide on identifying, isolating, and informing for emergency departments and ambulatory care centers for management of patients who are under investigation of Ebola. We hope in the future that we can expand this beyond Ebola to include some of those respiratory pathogens that Krista mentioned. But this is a tool that, again, we really hope to use. The SRHD received grant money to better prepare the Region 9 facilities for the chance that we may see Ebola. From this grant, a phone drill was formed to identify gaps and assess the readiness of the Region 9 frontline facilities. Too many buttons to push up here. Okay, so the goals for identify, isolate, and inform were to first identify the patient's symptoms, travel, and direct exposure history, and then to isolate. Isolate the patient immediately and avoid unnecessary direct contact. And then how would this patient be isolated and where? And then inform. Who are you going to call for notification once you suspect that this patient has a highly infectious disease? So the drill goals, it involved calling either the ED nurse manager and or the infection control nurse. On a couple of the interviews I was able to do, I had both. And to talk them through a scenario that would help them identify where the gaps might be through identify, isolate, and inform. So the main goal is to assess the use of the CDC tool, and then for identify, isolate, and inform to evaluate by implementing the phone drill. So the objectives were to determine the current usage and understanding of identify, isolate, and inform, learn which tools staff had been trained on and how these tools have been used, and to build the relationships with those frontline facility staff and to let them know that we are here to help. And to emphasize how not only the CDC tool can be used for Ebola, but for other emerging highly infectious diseases. And then we wanted to collect some feedback and evaluate. So this scenario, a middle-aged Caucasian female enters the ER complaining of fatigue, headache, fever, and is vomiting. She is confused and having difficulty articulating sentences. She left this morning for work and stopped by the emergency room when she was too sick to drive home. She recently returned from a trip to Nigeria 2 weeks ago, and in the scenario, Nigeria was having an outbreak of Ebola. So we wanted to challenge the staff to identify the patient has a high fever, recently traveled to a country with an Ebola outbreak. Isolate that patient immediately, and then inform, notify facility infection control, hospital administration, and hopefully local public health. So some of the additional drill questions were, is the room where you're isolating the patient private? What is the bathroom situation? Is there an in-room bathroom, or is it a covered bedside commode? And what types of PPE are you going to use? And then do you have enough PPE to last for the 12 to 24 hours that is required of a frontline facility? Where is the nearest Ebola or other special pathogens treatment center? And if Washington State was to develop a stockpile of supplies, what would be most helpful if you need any help at all? And then have you even heard about identify, isolate, and inform? And if you have, how often do you use it? So the drill findings, unfortunately, I was only able to contact 8 of the 16 facilities, and thank you to Daryl for all of his help with that for 4 of those. Many factors played into the low response rate. Part of was the transition in the position that I currently have. And some of my epi duties, I don't know if any of you heard, we had a very busy month of June with some pretty rare significant illnesses. And then some facilities were contacted several times and via email, phone calls, and we just never heard back. And unfortunately, we had one facility refuse to participate. So the 2014 Ebola outbreak was on the radar of many of the facilities prior to notification from the local health jurisdiction. Mostly it was through the media. All facilities already have travel screening questions in place in some capacity. All the facilities had enough PPE to last at least 24 hours. Most facilities did express interest in having statewide stockpile of supplies. Some facilities required basic infection control supplies like gloves, gowns, masks. Some did ask for PAPRs, and then we had some that asked for oxygen and as well as IV fluids. And then identify, isolate, and inform is actually being used in some capacity. It may not just be called by that. One of the hospitals said that we do this every day. The patient is triaged, isolated as needed, and then it is reported higher above if needed. So whether that's to the special pathogens unit or to the hospital or even consulting local public health, the identify, isolate, inform is being used in some capacity. So there were some gaps that were identified, and the information on this slide was taken not only from the drill, but from a post-drill survey. Unfortunately, we didn't have a high response on the survey before we closed it out. We had only received 5 responses out of the 8 facilities. So one of the gaps is to increase collaboration and communication between the facilities and the LHJs. I want to toot the own horn of the EPI staff at SRHG, but we really do, when we hear of an issue, like to notify the providers in our area, whether it's measles in Minnesota or whether it's Ebola in Africa. We do like to try and put that out so there is some awareness. And we have seen good response and heard good feedback from providers to receive this. So that's something that I would like to see happen as we continue doing this drill in some capacity or another, is to increase the communication between facilities and local health. And then travel screening, again, all the facilities that we did this drill with have some travel screening in place. However, we're not sure what the capacity is with that. Do they even use an electronic medical record system? Do they have like Krista was talking about, do they have a special screen that pops up when certain symptoms are entered? These are things we hope to continue to find out as we conduct more assessments. And then some of the rural facilities, which are small, did note the lack of the negative air rooms and the donning and doffing rooms. And then PPE training and the lack of time for staff education. Most facilities only require the PPE, maybe even the PAPR training annually. Some do it quarterly, but there was a lot of interest in increasing staff time and funding to provide more hands-on training, instead of just doing it online. And then one of the big things that I would like to include with the increased communication with the facilities and the LHAs is providing more tools and protocols like the handout that I passed to all of you to help with the education of staff and to use those tools as resources rather than the nurses having to find them on their own. And then one of the biggest ones was getting staff buy-in. especially in the rural facilities, you may think, I may never see Ebola, so what's the point? What we're trying to get at, and what Chris alluded to, was it may not be Ebola. It might be MERS. It might be a highly pathogenic avian influenza. So we really hope to increase the knowledge that just because you don't see people returning from certain countries doesn't mean they can't present at your facility if they're on vacation, visiting family, or whatnot. And then some lessons learned, and these are just pretty basic, was that the ED and the infection prevention nurses are very busy. It was often difficult to get response time. If I did, sometimes it did take a while, but that just required flexibility on our part. And then it's something that is in discussion. For me personally, I like to visualize it. So I would like to see the inside of an ER. Where are you going to place the patient? Where are you going to do this and do the donning and doffing? And then something that NETEC suggested was conducting a secret shopper drill where you actually have an employee or someone somewhere involved in the process present to an ED with symptoms and see how the process goes from there. Any questions?
Yeah, the NETEC site, I'm not sure if it's up there yet, but they are going to have some material that is probably most helpful to hospitals, but also urgent cares and ambulatory surgery centers and some of the other frontline hospitals or frontline healthcare facilities around the secret shopper drill. And it's really a pretty simple process. One of the things I told Malia that I really appreciated was doing these for our hospitals. I learned a ton just in a couple of days as we focused on this, and so it was really helpful. So we can point those out to the SRHD HCC site.
And NETEC has said that if a facility would like an assessment, whether it's a frontline, an assessment, or even a treatment center, they are willing to come out and do site assessments. So you can ask Krista, Daryl, or I about that information.